Dr. Shawn Tierney, and I'm an ultrasound specialist, and I guide procedures, including stellate ganglion block, on a regular basis. I think we've got it about 1,600.
Okay.
Shawn Mulvaney. I'm a medical doctor, certified in sports medicine and pain medicine, and I have published extensively on the stellate ganglion block for PTSD and chronic anxiety conditions.
Great.
I'm Dr. Jeremiah Maloney. I'm a board-certified anesthesiologist, and I work here in town in Temecula, and I assist Dr. Tierney with some of his stellate ganglion blocks and also with ketamine infusion therapy.
Well, fantastic. Let's start out. Let's talk a little bit about the stellate ganglion blocks, and can you guys give me a real quick summation of like where it kind of started and then what it's all about?
So in the military, this started with I can name the time. It was a patient came in. I was evaluating him after a motor vehicle accident, and he had crashed his car. And as I went through, I'm like, hey, so why'd you crash your car? It was the middle of the day. He's like, well, I fell asleep at the wheel. I'm like, why'd you fall asleep at the wheel? And he's like, I'm taking Seroquel, which is a very potent antipsychotic medication with somnolence as an adverse effect of it. And I'm like, what? All right, this is a person with a security clearance. I'd known him for a long time. I'm like, what are you doing on Seroquel? He's like, I saw another Army psychiatrist and I was taking it to control my nightmares. I'll take anything to get off of this. Seriously, I hate being on these drugs, but I've had this since Desert Storm. So he had over 14 years of symptoms by the time I was seeing him.
Wow.
And he described really some of the most accurate, what really made an impression on me, his descriptions of what we call a flashback. And people who don't have PTSD, including me, I never really had a good understanding of that. And really that flashback it's a memory without a timestamp. It's like if a tiger came out of a cave and chased us, and if we ran away and we survived, we would never forget that cave. That whole situation becomes a memory without a timestamp. The smells, the associations, everything about it. And so when we would recall that, it wasn't like recalling it like some time ago. It was the whole packet of memory comes back, and it's in fact happening now. So all of the anxiety, all of the fear for your life, all of the being amped, and the physical stuff that was happening as you were trying to survive, it all comes back in one crushing wave. And it's not a memory. It's not something that happened a while ago. It's a now. And so getting your head around that and trying to understand why these people have this horrible anxiety, this anxiety comes from that fight or flight nervous system getting stuck in the on position. So getting back to he had described very accurately the situation was he was in Desert Storm in the initial ground combat. He was part of an assault team moving through a bunker complex. Moving through, they were killing in close quarters inside the bunker complex. A door they came up against blew up back on him, knocked him unconscious briefly. He was back up and moving through the target, and as they were engaged in really a bloody, fierce battle. And he had all these elements. He had, basically, people who have responsibility for killing in combat or close quarters killing, especially when you see the person there. That is a huge, I don't know if risk factor is the right word, a huge factor in them developing PTSD, but also this element of traumatic brain injury, of some element of loss of consciousness and traumatic brain injury, also kind of lowering our normal resilience or defenses that we might have against it. So he described this to me. I'm back to the story now, your question. And he said, what do you have for me? And I said, I have nothing. I'm a musculoskeletal and spine doctor. I don't know anything about this, but I'll keep my eyes open. I will try to figure this out. And how it came to bear is a little bit odd. I was this is probably more than you want. There's a musculoskeletal conference in Madison, Wisconsin, and somebody walked up to me who I did not know, and they said, you're an Army doc, right? And they handed me a newspaper clipping, and the newspaper clipping was of this physician in Chicago named Eugene Lipoff, who had done stellate ganglion blocks to control perimenopausal hot flash symptoms in women.
Huh.
And he said, do you think this could have anything to do with PTSD? And it sounded like the most bizarre thing I ever heard. It sounded ridiculous. I didn't know who this person was. And then that little kind of voice reminded me, well, you said you'd check out anything. So I was like, all right. Took the newspaper clipping, looked the guy up, called his office. He took my call. I said, hey, I'm an Army physician. Do you think this could work for PTSD? He said, yeah, I think it could work for PTSD. He goes, I tried it on one guy and it seemed to work. And he'd only done it on one person with it. And I was like, okay. So I went back and I talked to the one soldier that had it. And I said, do you want to do this? He's like, yeah. I'm like, look, the procedure has been around since the 1940s. It's safe. But we don't know if it's going to work for your PTSD, but we can try it. He's like, let's do it. Did it. He had a phenomenal response, and I recall his words to this day, because when he was in combat, he was a 19-year-old soldier, and he looked up, and this is like 15 minutes after his block, and he said, I haven't felt this good since high school. And I'm like, what is that? I had another soldier come in who was a Marine, who was in the Battle of Fallujah. Again, brutal, close quarters combat. Tragic story. Comes home and he's so amped. His PTSD and anxiety symptoms that go along with that have him in the grip so bad that he hides himself in the upstairs bathroom away from his wife and children, and he can't even be around them. Like, he just has to hide. And cost him his marriage, cost him his family. This is now a couple years later after the Battle of Fallujah, and he's like, look, can you give me some medicine for erectile dysfunction? And I was like, look, you're 27 years old. I'm not going to say no, but I need to make sure that you're okay. What's going on? He's like, well, I'm taking Paxil, and it gives me these sexual adverse effects where I finally met somebody, and I think I want to date them. We haven't had sex yet, but I'm thinking about it and I'm nervous about it, so I just wanted to get some erectile dysfunction meds. I'm like, how about we just get you off that other med and then make it so you don't need it? He's like, yeah, let's do it. I go, I've done one of these and it worked, we can try it. He's like, let's go. Stellate ganglion block, and he had an outstanding result. He was one of these that falls in the category of like one and done guys. It's not like I lost track of him, and I still saw this guy for the next 10 years as I worked there. But his symptoms never returned. He just had to break that cycle.
Fantastic.
And that's the huge part.
That's awesome.
So that's where it started.
That's
and
the
then
start.
There it kind of went along kind of at a slow pace for a while, and then really we started treating a lot of SEALs. Once they found out it worked, they were like, give me.
Yeah, because what they're seeing out in the field is pretty traumatic stuff. I can't imagine how that goes for them. What have you seen as far as like you mentioned the one and done, but is that a typical thing? Is it multiple times? Is there an average, or is it all over the place?
Hey, this is the $1 million question. I want to hear what you guys have to say about it, because this is something that I've done over 1,000 of these blocks. I know these guys have done over 1,000, so it's not like we don't have experience with this. I see some people, they just need to break the cycle, including, and the duration of the trauma doesn't seem to matter. I had a Vietnam veteran who had PTSD from the Tet Offensive in my office. He's in his 70s, he's sobbing, he's crying, holding his wife after his block. He's like, that's finally done. It's crazy, hugely powerful. And I haven't lost track of this guy, and he's doing great. He just needed to break that cycle.
Right.
Some people, that's where they're at. And I'd say it's about 35%. I was saying closer to 50%, but I've seen over the years, some of those people have now come back, where what can happen is they can get re-triggered. So people with PTSD, even if the stellate ganglion block makes them better, they can still be around things that re-trigger them.
Right.
So there's different categories of people. Some people are the one and done. That's nice and happy. Some people, they get better, but not all the way better, and then they might slowly degrade over time. And some people just get better and they're doing great, and then a year later, something triggers them and they come back. An example of that would be one of my medics, combat medics, was deployed to Afghanistan, involved in close quarters killing in combat, comes back, and he knew I was doing these. He's helped me do these in the clinic. And he's back, he seems pretty normal. His wife calls me a week later and says, what are you gonna do about Uriah? I'm like, what are you talking about? She's like, he's sitting up and drinking himself to sleep in the chair. He's checking the doors and windows all the time. He's being a total ass to like the kids, to me.
Mm-hmm.
He goes, it's not the same guy that left. And so the next day I'm like, hey, your wife timed you out, get on the table. All right, he gets on the table, we do a block. She calls back, he's back. My husband's back now. Everything's good. And he was fine. And didn't lose track of him. And then a year later, his office mate that he worked with, another combat medic, is deployed to Afghanistan. He sends back on the secure email that he'd been in a conflict where he just killed 3 people in close quarters.
Right.
And then Uriah the original guy felt his symptoms, not like spike, but they started coming back.
Ramping up a little
He's
bit.
like, hey, I'm feeling it coming back again. I'm feeling that feeling, which this is a really important point. Now, this is on a Joe Rogan podcast. Dakota Mayer, just in a recent podcast on the Joe Rogan show, he said something that was really poignant. Dakota Mayer is a Medal of Honor recipient Marine.
Right.
Great guy and a real advocate for helping out veterans and actually a real advocate for PTSD, SGB for PTSD. But what he said was, I had this feeling in my chest and I felt really bad, but I didn't know what it was, and it was anxiety. Because he wasn't an anxious person before he had this. And it just goes to show, like, some people just don't have the words
Right.
to wrap around it. Like, what am I feeling? What is this bad feeling? They know that they can drink and it feels better.
Right.
They know that it doesn't make it feel better. It numbs it. It's still there, but it's less troublesome. And so you see a lot of people self-medicating with alcohol or other drugs. Yeah.
So it is kind of a strange question. Are the results immediately when they get the stellate ganglion block? Is it days later? What typically are you seeing? You mentioned one where it's like just within minutes they're feeling better. Is it always the case that way, or do they have a delayed response sometimes?
So usually what I see is we'll see how they're doing, and we'll score how their Horner's syndrome is doing 5 minutes after the block, and we'll check on them. And then I let them kind of marinate. Almost always within 20-25 minutes, we're going to start seeing some signs. I don't like to tell people what they're going to feel. If
Sure, no, I
patients,
can appreciate that.
But it's good. It's definitely good, and I'm happy to talk to you guys about it. And occasionally, it'll be a delay, not because it didn't work right away, but because some people are they're looking for it.
Mm-hmm.
They're looking for the anxiety, and they don't believe that it's really gone. So they're kind of very guarded in their response.
Sure.
They're like, and you have to get them a week. You know, I follow up on everybody, a week, a month. How are you doing? And we have to get scores. Sometimes you even have to ask their spouses or people they live with, how are they doing? Oh, he's a different person. He's totally better. And he's like, I don't know if I feel any different. And they're like, oh my God, you haven't yelled at the kids in 3 weeks. You know. What do you guys see?
Similar. I mean, it's really common to see a change right away before somebody gets off the table. Usually they lay on the table for a while. But it also happens that sometimes people say, hey, you know what, I went home, I took a nap and I felt great, or I went home and the next day when I woke up I felt really good. It seems like people who have been in that state for a longer time may feel really good right after the block, and then for a couple days following it may be a little bit up and down until it evens out over about a week or 2 weeks, and then they're like, okay, I'm here, you know.
Right.
So there's a variability. The vast majority, I think, you know, like Shawn said, is that it's going to happen on the table. But I certainly don't expect that to happen. I don't think patients should come in there thinking, oh, I'm going to feel better on the table, or else it didn't work.
Right.
You have to just, you know, see how you do. Let it go the next day. How are you in 2 weeks? You know, that's kind of how we follow up with you too. You know, we're going to see how you are after the block. We want to see how you are in 2 weeks. We want to see how you are in 2 months. So we want to track. So for the most part, you know, people notice a profound change. And then when you don't notice profound change, then there's possibility that somebody may need to get the other side blocked. Typically what I see is with that other side is just like Shawn was saying, like that I don't feel that much different, but their family's like, you don't yell, you don't do this, you don't do this. Like, yeah, but I don't feel that much different. So I think there's something about a profound block for the patient, like that sometimes they get a great block and they do better with the right, but they don't feel normal until they get the left-sided done.
Got it.
So there is that percentage, and I think it's definitely less than 70%. I don't think we have a really good number on it, but there's a percentage of people that end up needing that other side to get the profound change that they're looking for.
Yeah. And just backing up to your other question, so really what we're trying to still work out is what's the optimal sequencing for people.
Right.
Generally what I do is, because I don't like to tell people they need treatments that they may not need, I just follow their symptoms and see how they're doing. If they're improving and then they start to degrade, then it's time to come back in for another one. In the study that we just published in JAMA Psych that just came out, we did a series of 2 blocks scheduled. It was a block, and then 2 weeks later another block, stellate ganglion block, and that showed, compared to a sham injection, basically showed causality, that the stellate ganglion block statistically and clinically improved their symptoms. So we're looking for the right sequence on things,
right?
But it's hard to pick out. I haven't been able to tease together whether it's the severity of symptoms. Honestly, sometimes I think sexual assault needs to be treated, rape victims need to be treated more, and the reason why is because the triggers are so prevalent in our society. It could be someone standing next to them, it could be someone that smelled like the person that did that. So there's subject to a lot more triggers, but we're still trying to put that together, actively trying to put that together to let people know, hey, this is how it should be. I think the way we've gone with is following the symptoms. And then I think with the left-sided block, I usually see overwhelmingly people respond to a right-sided stellate ganglion block. There's a small fraction, and I think it's like 5% of people who don't respond to a right side will respond to a left-sided block profoundly in exactly the same way. And then what Shawn's talking about is this, Dr. Tierney's talking about, is this middle ground that we're just sorting out. Now, you can explain that we're wired. Some people have their heart on the other side of their chest. It's called dextrocardia. It's on the right side instead of the left side. Some of us are just wired different.
Sure.
What Dr. Tierney's talking about is some people will not get a kind of complete response, and we don't know that fraction. I suspect it's closer to like 15% where they'll respond really well to a right-sided block, but incompletely, and they may benefit from a left-sided block. These are things that the research has to guide us. Right now, the only reason why we see them is because we're doing these at such high volumes and taking care of a lot of people. Is that what you're seeing? Or?
Yeah, I mean, since I parallel with what Dr. Tierney says, since we work together on this patient population, but it's slightly different for us because where Dr. Mulvaney, your primary practice is with a lot of Army and military people and PTSD, you're seeing tons and tons of that, and although we're seeing that as well, we're kind of dealing more with the civilian population. So some of their problems, complaints, issues, things that they're looking to get relief from might be different than some of the things that are afflicting some of his patients. But the beauty of it is we're finding that it really is universal and it really carries over. And so we're able to treat patients. I mean, we've treated patients as recently as today who suffered from the shooting situation that occurred back in Las Vegas. So again, another PTSD type of a occurrence, but oftentimes we're helping people also who, not just with PTSD, people who are suffering from like severe insomnia. We've had people, because they're having constant, not one additional or one instantaneous focus or one point that they can say is their particular trigger, but just whether it was a series of childhood problems or things that have occurred with them where they're constantly replaying these harmful memories in their minds, where we're able to really alleviate a lot of that and give them quite a bit of benefit.
Yeah, and it's in I've been out of the military now for about a year and a half. I still do attract a lot of vets, but I'm seeing, across the board, civilian, full
so
spectrum.
You're getting a nice balance.
Yeah, so, but what I see is that military-related PTSD looks and presents and responds exactly the same as, let's call it, like I call it EMS related, whether it's police officers and firefighters, which we've now been very successfully treating. There's also civilian trauma, people like the Las Vegas shooting victims, who that's very similar. kind of flavor. You're getting into a little more harder to eradicate now. If it was like one assault, one incident, that's one area in sexual trauma, and then there's I put it into this childhood trauma bucket, which is childhood trauma or more complex PTSD. That's very challenging because it's not like you're trying to eradicate one thing. This person's self-image is actually changed and they become they see themselves as an anxious person. Harder to eradicate. But just so I'm clear, I really don't, at this point, I don't feel it's productive at all to ask patients the nature of their trauma. I don't. So when they come in, I ask if they have a diagnosis, I ask what their diagnosis is, I screen them to see if they're an appropriate candidate with like a PCL5 or some other questions that we ask. But I really think it's important not to go into the nature of their trauma. And I can't tell you how many patients are actually really relieved to not have to talk about this with someone that they're just seeing for a procedure.
Yeah, they don't want to relive it.
Right.
No, it's very painful. And I see some physicians, they do it because either they're curious or they're trying to stratify their patients better, but I clinically think that that's a mistake. Not the least of which, when I first started doing this, I was a military physician, so the people I was treating, they were my guys being non-gender related,
Right.
because we had male and female soldiers that we were working with. They knew me, they trusted me, and so they would bring up the nature of the trauma. And I was, I am, a level guy, a resilient guy, take good care of myself, stable family. After a couple years of hearing those stories that you cannot unhear, I noticed that I was starting to get some of the stuff. So really, I think that insulating myself partially and insulating my staff from these stories is actually very important, because these stories are something that they're like, it's toxic waste.
Sure.
And if you're around it, it's going to get to you.
Mm-hmm. You mentioned childhood trauma, and today, tragically, there was a shooting in a high school, and several kids were killed. Is there an age limit to this occurring? I mean, like, would you treat a teenager, for example?
Absolutely. I've treated as young as 13, as
Okay.
long as I sit down, I have the conversation with them. Their parents are in the room, but I say, this is not something I'm doing to you, it's something I'll do for you only if you want. If you don't want it, then we're done here. It doesn't matter what your parents want.
Right.
And so if they've been subject to trauma and they're having these anxiety symptoms related to that, I think it's actually very important to actually flip them out of it sooner rather than later,
Right.
in as much as you can.
Right.
You can't change the memories, and that's not the point of an SGV. What you're changing is the body's stuck fight or flight response that you can actually reset. We're seeing full evidence of resetting, whether it's through changes in neural imaging, before and after stellate ganglion block. We're seeing these patterns change. It really is about whether or not and I wouldn't do a child in this way, but I think that if it's a youth and they understand what's going on and they want this done, that would be something that I would offer them responsibly.
Okay. So I know you've got some other information and articles and stuff. You bundled it all together. Could you repeat your website so I can direct people that direction?
For people that are looking for resources on this or more information on this, it is just a SGB, stands for stellate ganglion block, so SGB for the number 4 PTSD, SGB for PTSD.com.